I thank my co-authors for the opportunity to present this 14-center collaborative project at the Canadian Ophthalmic Society meeting. At the end of this session, you'll be able to risk stratify patients with suspected giant cell arteritis using an online calculator. Our June 2019 survey confirmed that the majority of clinicians in North America and Europe still prefer temporal artery biopsy over ultrasound as the confirmatory test for giant cell arteritis. As our population ages, we'll continue doing more temporal artery biopsy chores. However, at least 75% of biopsies return negative, skip lesions notwithstanding. The large number of negative biopsies is driven by risk-averse physicians worried about the possibility of blindness from undiagnosed giant cell. Multiple studies find that computerized algorithms are superior to clinical diagnosis because humans can't accurately weight multiple clinical variables. As such, it behooves us to consider prediction models for giant cell arteritis. I discuss our recently published prediction model from an oculoplastic surgeon's perspective. Our model used the 10 predictor variables of age, gender, headache, jaw claudication, temporal artery tenderness or pulselessness, diplopia, vision loss, erythrocyte sedimentation rate, C-reactive protein, and platelets to determine the risk of biopsy-proven giant cell arteritis. Age and blood work variables were maintained as continuous to improve statistical power. There was no multicollinearity. From the 14 medical centers, we found 1,833 consecutive patients who underwent temporal artery biopsy, 1/4 of which were bilateral. 1,201 subjects had complete data on all 10 variables, with 300 cases of biopsy-proven giant cell. Logistic regression and neural network models were formulated. On logistic regression, platelets, jaw claudication, age, and vision loss were more valuable predictors than ESR, CRP, headaches, and scalp tenderness. Gender and diplopia were not statistically significant variables. Neural networks had the advantage of being less affected by data outliers than logistic regression, but require much more data. And the back-propagated weightings as shown are a relative black box compared to the odds ratios of logistic regression. The risk score box plots show there is overlap in the clinical features of the negative and positive biopsy groups. Both models had good discrimination and calibration, but there were fewer false negatives with the neural network model. The sensitivity of both models is suboptimal at the traditional cutoff of 0.5. To achieve a 99% sensitivity, a 7% cutoff value is needed. The address of our online calculator is in the abstract of our open access article. Once again, to achieve 99% sensitivity, use a 7% risk score cutoff. Let's see how the calculator performs with low and high-risk clinical scenarios for giant cell arteritis. The prediction profile curves from the neural network model are shown in the purple rectangles. In the case of an asymptomatic 50-year-old with mildly elevated ESR and CRP, his giant cell arteritis risk is 1.7% on logistic regression and 4.5% on neural network. If the same patient had vision loss, the risk is 4.2% on logistic regression and 8% on neural network. Notice that when the patient lost vision, the profile curves for age, jaw claudication, CRP, and platelets all increased. If we have a 65-year-old woman with headaches and C-reactive protein twice normal, but normal vision, she has a GCA risk between 4.5% to 5.4%. With vision loss, the risk elevates up to 12.7% on logistic regression and 17.6% on neural network. Once again, the risk profile curves continually shift depending on the predictor variables. Few humans can make such nonlinear weighting calculations in their head. If we use the same parameters in an 80-year-old woman, even without vision loss, the risk score exceeds 11%. With vision loss, the logistic regression suggests 26% risk of GCA and the neural network 32%. A possible application of our model is to only biopsy patients with a risk score of 7% or greater. In our study, this would have avoided 14% of the biopsies that were eventually deemed negative. In patients with a less than 7% risk score, consider Doppler ultrasound or an alternative test, and if negative, contemplate another diagnosis. If the ultrasound suggests a halo, I would still recommend confirmatory biopsy of the suspicious area due to the risk of long-term glucocorticoids. The potential weaknesses of our study include its confined to biopsy-proven giant cell arteritis, its retrospective nature, an inability to recognize the full spectrum of giant cell arteritis presentation. The strength of our model includes its large size, generalizability to internal medicine, its online calculator, and compliance with the tripod guidelines for the transparent reporting of multivariable prediction models for individual diagnosis. In the future, we might combine our prediction rule with imaging tests, genetic studies, or ocular blood flow tests, and perhaps decrease the reliance on temporal artery biopsy. In summary, our neural network and logistic regression models are good card counters when gambling in the casino of giant cell arteritis and may reduce the number of biopsies you perform on low-risk subjects. Although statistical algorithms usually outperform clinical diagnosis, the mathematical models are meant to complement but not supplant clinical judgment. Thank you for your time. Cell can present in a protean and sometimes occult fashion. The American College of Rheumatology classification criteria are not diagnostic criteria and can misclassify many cases of giant cell arteritis.